In this section we are talking about an oral pharyngeal airway, also known as an OPA. We use an OPA when the patient has a GCS score of 8 or below and a verbal response score of 2 or below. An OPA comes in many different sizes. It is important to get the size correct because if it is too big, it will further induce vomiting, and if it is too small, it will occlude the airway by pushing the tongue posteriorly. To measure the OPA, we put it laterally on the corner of the mouth to the corner of the mandible, and we measure it up. So this is a perfect fit. So before we insert the OPA, we must do a chin lift. This opens the airway so we can put the OPA in easier. So to put the OPA in, we must rotate it 180 degrees, then insert it to the curve of the roof of the oral pharynx. Once it is at the curve of the roof of the oral pharynx, we twist it 180 degrees, and then we push it in. Now that it's in, this allows for oxygen delivery to be much more efficient. In this section we are talking about a nasopharyngeal airway, also known as an NPA. An NPA is used when an oral pharyngeal airway is not successful. It is also used when the patient has a locked jaw and a high GCS score. It is contraindicated not to use if the patient has a base skull fracture. The positives of using an NPA is that it doesn't initiate a gag reflex, hence vomiting is not an issue. But the complications of an NPA is that it can cause bleeding and nasal polyps. To use the NPA, we must lubricate the NPA with a water-based lubricant, and then we measure from the nostril to the corner of the mandible. Now that this is a perfect fit, we insert the NPA through the nostril, generally the bigger nostril, and then halfway through we rotate it 180 degrees, and we keep pushing in. If there is complications, however, we must keep inserting it 180 degrees, and then we push it in until the end of the nostril. This ensures smooth oxygen delivery. In this section we are covering suction. Suction is used when there is excess fluids obstructing the airway. So we must test the suctioning unit before we use it. To test the suctioning unit, we turn it on and we occlude the airway of the suctioning unit and watch for a rise in the gauge. Sweet, it's all good now. So now, to initiate the suction motion, we must put our finger over this hole. Then you go in as far as you can see and suction on the way out no longer than 10 seconds. So the complications of doing it for more than 10 seconds is that it can cause bradycardia, hypoxia, soft tissue trauma, aspiration, induced vomiting, and laryngospasms. Now I'm just going to demonstrate the use of it. So we're talking about oxygen delivery today. First we must ensure to see if we actually have oxygen. So sweet, it has oxygen. We must see if it is full or in use. So yep, this is in use. Then we must check the Bodax seal on the regulator to see if there's anything wrong with it. Sweet, the Bodax seal is all good. So now we must attach the regulator on the oxygen tank, and while we are tightening the regulator we must do quarter turns as we are applying it on. Now that it is on, we must check the O2 levels to see that all the flow rates are going. But before we do that, we must see how much oxygen we have in the tank. So just turn it on without any oxygen flowing, and we have a full tank of oxygen. Now I'm just going to measure the flow rates that it has. So see, it seems like all the flow rates are going quite nicely. So that's all good. There are different masks that we can use when we are using the oxygen tank. We can use nasal prongs, which deliver oxygen at 30% at a flow rate of 2 to 4 liters per minute. A nebulizer, which delivers 60% oxygen at a flow rate of 6 to 8 liters per minute. A non-rebreather mask, which delivers 90% oxygen at a flow rate of 10 liters per minute. And a bag valve mask, which delivers oxygen at 98% at a flow rate of 15 liters per minute. Now I'm just going to attach the nasal prongs, and I'm going to turn it on to 4 liters per minute just to see if it is actually working. So I can feel that there's oxygen coming out of them, so it's all good. So now we must turn off the oxygen and just turn it off, and now I've got to flush off all the excess oxygen. So by doing this we must make sure that it is closed, the oxygen is closed, and then we just turn it on without the oxygen running, and we have flushed out all the oxygen. Now I'm just going to be demonstrating the use of a back valve mask. First I must check to see if there's backflow, just placing my hand over here and pumping it so there's no backflow. So I'm just going to attach my back valve mask like so, and I'm just going to hook it up to running oxygen at a flow rate of 10 litres per minute, and ensure that the reservoir bag isn't leaking. So now it seems to be filling up quite nicely, so this ensures that there's no leaks. So while that's filling up, I must perform a head tilt chin lift and then insert an OPA. So now that my OPA is in, I can now ventilate the patient every 5 to 8 seconds. So now that I'm going to ventilate the patient, just assessing for chest rise. I also must check for gastric inflation. If there's gastric inflation while I'm ventilating, I can have the use of a second officer to apply cricoid pressure. So in this section I'll be covering hemorrhage control. First we have to expose the wound on its forearm. So before we apply anything, we must clean the wound with saline. And as well as that, we must apply saline on the gauze strip. This is to add direct pressure. Then we use a combine dressing and we pack it up as tight as we can to add more direct pressure. Now that this is on, I can use of my offsider to elevate the arm to reduce bleeding, and I can apply a crepe bandage on to help give more pressure. Using the crepe bandage, I can add twists to add more direct pressure, and using a figure of 8 motion while I'm doing this. Once the crepe bandage finishes, you can either tape it or you can just tuck it in like so. If the bleeding continues, then a second bandage can be applied, but if it is still bleeding, then we can use a tourniquet. On the arm, a tourniquet must be applied 10 centimeters proximal to the wound in a D loop, but if it was on the leg, we can use a double D loop. So we tighten it, and then we must tighten the windlass until no pulse on the distal part of the wound is felt, and the bleeding stops. Once the windlass has been tightened, then we can put the time. If the bleeding still continues, then a second tourniquet can be applied. Today I'll be looking at fracture management. So to do this, we must expose the limb, comparing both sides just to check to see if there is a fracture. To assess if it is a fracture, we use the plustis mnemonic, which stands for pain, loss of function, comparing the swelling on both sides, deformities, irregularities, shortening, crepitus, and shock. So once we have established that as a fracture, in this case it is a tibular-fibular fracture, we must assess the cardiovascular and the neurological deficits. So to assess the cardiovascular deficits, we must look at the colour of both feet, compare the temperatures, look for pedal pulse on both feet and the cap refill. So now that the cardiovascular check has been done, we also must look for neurological check. So that includes motor function. So could you please move your toes for me, please, sir? Just, can you feel my fingers touching your feet? Sweet. So neurological. So here's some neurological deficit. Then we must ask for pain. Sir, what's your pain?
Probably about a 7 or 8.
Sweet. So this is about mid to severe pain, so we must give drugs in the form of an analgesia. So in this case, I'll be giving Entonox today. So before we must administer the Entonox, we must check the expiry date. But before we do that, we must ask if he has any patient history. So, sir, do you have any allergies to drugs?
No.
Have you been scuba diving in the last 24 hours?
No, I haven't.
Have you been having troubles going to the toilet?
No, that's all good.
Is there any pain on breathing?
No.
So yeah, he can take Entonox, and I just got to explain to him that there's side effects to it. So, sir, when you are taking this drug, there may be some auditory echo, there may be some metallic taste in your mouth. You might feel a bit nauseous and dizzy. You might feel euphoria. Don't worry, these aren't all going to be present, but some may present. So,
okay.
Yep, sweet. I'll just get my offsider to check the Entonox.
April 2017 this week.
So I'll just have a look at it again, and yep, so it is not expired. So just explain to the patient the process of the Entonox. So sir, you are in control of how much pain relief you give, so just give 5 to 6 deep breaths for it to start working. So now we can splint the limb. So I just asked my secondary officer to just lift the leg up while I attach the splint, the box splint. So, sir, what is your pain now?
482.
Sweet. So we know that the analgesia is working. So to splint the limb, we must go above the fracture and below the fracture. So just get my officer to lift the leg up for me and just tight it, but not too tight that it blocks off the blood supply. So that's all right. And then down below. But when we go down below, we can use a figure of eight motion to tie it up. And we can go in the middle as well. Doing these three ensures that the limb is stabilized. And after we have splintered, we must check for cardiovascular and neurological integrity using the same checks as before. Demonstrating the use of a cervical spinal collar, also known as a C collar. The indications for a C collar is if the patient has a neurological deficit. This means that on palpation there is no sensation or if there is tingling or cramping in the joints. Another indication is if the patient has a mid-spinal tenderness on palpation on the neck or on the spinal region, an altered level of consciousness, a distracting injury, or intoxication. Also, you can also take into account the mechanism of injury. So to apply the cervical spinal collar, I must use my secondary officer to support the head. Then we must adjust from the top of the shoulder to the corner of the jaw, and then measure it up on the C collar. So this is a nice fit. Then we go under it, and ensuring that it is tight but not too tight. Then we must reassess to see if the airways are still maintained. So now I'm just going to demonstrate how to use the LifePak 15. First we've got to turn it on. Turning it on will automatically put it to AED mode, so to change it from AED mode to manual mode, we press Energy Select, and we just turn the knob like that and hits manual mode, and then we just press the energy and it'll take us to the screen. So to do an operational check, we press the options button and press user test. While this is in progress, I can just check to see if I've got my aspirin and G10 in this pocket, my defib pad in this pocket. Just got to check to see that the SpO2 is connected, the NIBP is connected, and the ECG is connected, and just see if our entitled CO2 is there. Also, while the operational check is in progress, we can check the batteries. We can see that there's one bar in battery 1 and a full battery in battery 2. Also, we can just flip it around like so, and just open it up like that, and just check, just press these buttons to see if it lights up, and battery 2 has a full battery and battery 1 has one bar on it. So now that my user test has finished, I can just rip it off. It says that the user test has passed, so that's all good. So now I'm just going to do a test defib shock, but I just got to press the energy back to 50 joules before I do this. We're pressing the energy select button and just rotating the knob until I get 50 joules. So just by attaching the test load, like so, and then we can charge it. So charging it, we can either shock the patient or we can disarm the charge by pressing the selected knob. So, just going to put an ECG simulator on now. And we get our normal sinus rhythm. So, to change the leads, we can just press the lead button, and we have a bunch of lead options that we can do, but for the sake of this demonstration, I'm just going to go to the lead 1, 2, and 3. So, now that I've got this mode on, I can change the amplitude of it by pressing the size, increasing it, or decreasing it like so. So, for now I'm just going to put it back to 1, and then we can also change the QRS volume by just rotating over to the heart rate, and then selecting it, and then just pressing it, and then just increasing the volume like so, or decreasing it. Also, just got to check that, also to use an invasive blood pressure cuff, just it is located up the top. Just see, just put it on the patient's arm and press the NIBP button. So, and also to put this entitled CO2 on, just bring the CO2 out, turn it clockwise into this hole over here, and then we can connect it to a bag valve mask to measure the CO2 levels. This is pretty good in a cardiac arrest situation. And also just got to check to see if the ECG paper is in there. So it looks like we have a full roll. So I'll be doing vital signs today. There are three vital signs. There are three vital signs that I'll be taking today. That's the heart rate, the respiration rate, and the blood pressure. So for heart rate, there are different pulses located in the body. There's a radial pulse, a brachial pulse, a carotid pulse, a femoral pulse, and a pedal pulse. Before I take his pulse, I must gain his consent. Hello, sir. Could I please take your pulse today?
Sure thing.
So for the sake of this demonstration, I'll be taking his radial pulse. So I will get the beat, and then I will time it for 15 seconds, and then times it by 4. So his heart rate was at 72. That is well within the normal range of an adult heart rate. Also, while I was taking his pulse, I was noting the strength and the regularity of the pulse. For respiration rate, I must assess the patient's chest for chest rise. I'm doing this for 10 seconds on inspiration and expiration, but I'm not telling my patient this, otherwise it may affect results. So I got a result of 18 breaths per minute. Also, to measure the volume and the clarity of his breaths, I must auscultate his chest. So to do this, I must use my stethoscope, and I must listen to all 4 of the lobes anteriorly and posteriorly. But for the sake of this demonstration, I'll be doing it just anteriorly. But before I must do this, I must gain consent of my patient. Hello, sir, could I just go into your chest and measure your lung sounds, please?
Sure thing.
So could I just get you to breathe in for me? Breathe out. Wait, could you breathe in? Breathe out. Can I just go under your shirt now? Can you breathe in? Breathe out. Can you breathe in? You breathe out. Sweet. So, when I measured his chest on auscultation, it was perfectly fine. But when I'm measuring for volume and clarity, I must be aware of wheezes on expiration, stridor on inspiration, and crackling. For full respiration assessment, though, I can measure the SpO2 on an SpO2 monitor, or words per minute. So I'll be taking a blood pressure today. First, I must gain the consent of my patient. Hello, sir, could I please take your blood pressure?
Yep.
So before I apply my cuff, I must remove any restrictive clothing. So I'm just going to roll up your sleeves, and then I'm just going to measure my cuff up. And before I apply it, I must find the brachial pulse. So just let me feel for your pulse. Sweet, it's about there. Then I'm going to line my cuff up to the brachial pulse, and then I'm just going to tighten it. Again, just grab my stethoscope and put it on the brachial pulse. And I'm just going to pump up my sphygmomanometer to 140 millimeters of mercury. So just pumping it up and releasing it. So I hear the first heartbeat at 110, that is the systolic level. And it is disappearing at 70. So that is the diastolic level. So his blood pressure is 110 over 70. This is well within the normal range, which is 120 over 80. Okay, so we have just been called to a cardiac arrest. Before we enter the scene, we must be aware of all the hazards, and especially this is a classroom environment, just be aware of all the desks around and just students running in and out, knowing who the patient is. Also, me and my offsider must have our personal protective equipment, our glasses and our gloves. So before we enter, as we enter, we must ask for for history, like, hello there, sir, do you know what their name is?
No, sorry.
Do you know what happened to the patient?
I just came in here and found him collapsed.
Sweet, okay, so now I'm just going to check for a response. Hello, can you hear me, sir? Sweet, so he is not responding. Can you please call an R50 for an R49, please? Yep. So while he is doing this, I'm just checking for his breathing for 10 seconds.
R50 for an R49.
So can I just get you on compressions, bro? Well, so it's
Yep.
AED. Sweet. So turn it on.
Analyzing heart rhythm. Do not touch the patient.
Clear, bro. So while this is going on, just have my OPA ready.
Charging. Stay clear of patient. Deliver shock now.
Clear.
Press the on
Shock.
shock delivered.
So just jumping on compressions, bro. So while he's doing this, I'm just inserting an OPA to free the airway up, and then just connect my back valve mask to a running oxygen. While I'm doing this, my secondary officer is just doing a compression rate of 30 compressions, putting the oxygen on to 10 litres per minute. Sweet, when you're ready.
Yep.
Sweet. So chest rise.
Chest rise.
Sweet. Chest rise.
Chest rise.
Sweet. So can I just get you back on there, please? So if the patient is vomiting, we have our suction machine ready, just on standby, so we can perform a log roll. Sweet. And chest rise.
Chest rise.
Sweet. Chest rise.
Chest rise.
Sweet. Next time, can I just get you to apply critical pressure? I'm quite worried about that gastric inflation. Sweet. Chest rise.
Chest rise.
Sweet. Chest rise.
Chest rise.
So the critical pressure is just to ensure that the oxygen goes to the lungs and not to the gastrointestinal tract. So sweet. So when the AED goes off again, we'll just swap around. Is that all good?
Yep.
Sweet.
25, 26, 27, 28, 29, 30.
Sweet. Chest rise.
Chest rise.
Sweet. Chest rise.
Chest rise.
Sweet. Sweet. Chest rise.
Chest rise.
Chest rise.
Chest rise.
Sweet. So he's doing compressions at a rate of 100 to every minute, and he's going 1/3 of the chest cavity. Sweet. Chest rise.
Chest rise.
Stop
Sweet. Chest
CPR.
rise. Sweet. We'll just swap over now, bro.
Analyzing heart rhythm. Stay clear of
Clear.
Analyzing heart rhythm. No shock advised.
So I just jump on the compressions now.
If needed, start CPR.
Forward 25, 26, 27, 28, 29, 30. Sweet. Ventilations.
Chest rise.
Sweet. So now that the patient has a return of spontaneous circulation, if the patient is breathing on his own, then we can just put him in the recovery position, but if he is not, then we can just continue to provide ventilations. Also, we could just get the patient ready for transport and prepare for rearrest.